neurosurgery. It's not the easiest pathway in medicine to take. So it'd be great to get a perspective on what drew you to the field, the discipline, and also particularly the work that you're doing right now in trying to find brand new ways to tackle brain tumors.
Yeah, no, thank you for asking that. I think I can sum up my interests, or what got me into neurosurgery, really with respect to what got me into medicine in general. I'll be honest, I don't come from a healthcare family, no doctors in the home or anything like that. When I was young, my mom was studying to become a nurse, and I was taken care of by my grandparents. My grandfather got sick when I was little, and he ended up with pancreatic cancer. And in the process of that, a young 5, 6, 7-year-old, it was right around that time period when I was living with my grandparents and my mom was still studying, I kind of became my grandmother's sidekick, right, in terms of taking care of him. And so that engagement with healthcare and just understanding, like, taking care of people and what that feels like from an early age really set in. And you combine that with my mom then, who's a nurse, and going to CME events and hanging out at the nursing unit with my mom after hours and things like that, really drew me into healthcare. Now that's what got me interested in medical school. Once I was in medical school, imagine, again, I don't have doctor parents, so I came in with a pretty open slate, open mind, and I just started to meet people. For me, I was really influenced by the people I met. I met a neurosurgeon named Nino Kioka. At the time, he was the chair of neurosurgery at Ohio State, an amazing person. He was a thoughtful scientist. He was a really good doctor and surgeon, cared about students, and he said something simple, not provocative. He said, "You're interested in neurosurgery and interested in science? Come work in the lab." And so, nights and weekends throughout my entire 4 years of med school, I just worked in the lab with Nino Kioka and Sean Lawler. So my view of what neurosurgeons did was really as it related to Nino, and which included science and investigation, particularly for a disease type in which we don't have good answers.
Right.
And so, this combination of having healthcare issues with my family, again, focused on cancer, healthcare issues, and having great mentors is really what got me there.
That is a great answer.
Okay, I wanted to be like him. It was just that simple.
No, we should all be so lucky, right?
Yeah, that's
At
right.
some point along the line. So one of the things that I really loved about your talk was how you, the world sees neurosurgeons as technicians, honestly. I think you probably get this.
Yep.
They go in, they cut, they leave.
Okay.
Clearly that is not what you do. The things that came through were your understanding of individuality, right? A real appreciation for that in this world where we do connectomic maps of everything. And also the understanding that the idea of the balancing of how you begin to approach a patient who comes in with a set of symptoms, has an MRI, and has this potentially devastating diagnosis. What are the things that you consider when you're deciding to go in versus not?
So there are, the things that I consider when deciding whether to offer an operation or not offer an operation really depend upon established guidelines. It's pretty well established who benefits from surgery and when, and they've been beneficial to be part of that conversation and figuring out not just what type of patient, but what type of tumor molecularly and what our surgical targets could be. Turns out that within that context, just removing the tumor in its entirety isn't always the right thing.
Right.
Now, you do want to, right? Our goal is to remove as much as we can, but safely. For example, if I remove a tumor and permanently cause an injury to somebody to the point where they can no longer move the right arm and leg, I've actually walked back some of the survival benefit from cytoreduction or removing the tumor. So it's that balance. Some people describe it as an oncofunctional balance or a behavioral functional balance. It doesn't matter what terminology you use, but the patient needs to be able to do a core set of things that not just allows them to engage with society, but also walk their way through cancer-based therapies. Quite literally walk their way through. right? And if they can't do those things, the outcome for them is worse.
Right.
Now, that means that sometimes we have to leave a bit of tumor behind. And that's what the laboratory is based on. I've been, really blessed to have just amazing trainees in the lab where we really study the leftovers, right? So we're studying the leftover bits of tumor that can't be removed and what's the computational ability of those bits of tumor, right? Or really not just tumor, but brain, right? And also really thinking about, about looking at what I call garbage data. And when I say garbage, it's great data and an interesting way of thinking about cancer, but it's really information that's typically been discarded by many research programs.
Into the CUSA.
That's right, into the CUSA or electrophysiology data that we've never focused on because we thought it wouldn't tell us anything meaningful.
Right, and that is one of the things I was going to ask you about with respect to the fact that I was on the advisory for the Brain Initiative in its early days, and the whole idea of being able to record from pieces of human brain that are removed as a result of surgery really was initiated in the early days there, and now it's been taken to a number of different levels. And I think one of the things that your talk this morning highlighted was that tumor is a tumor. There's this deeply intimate relationship between all the different subtypes of cell in a tumor and the neurons that they are intimately connecting with. In your world, where have, because obviously we've had awake brain surgery for neurosurgery for a long time.
Early 1900s.
Right. We wouldn't have a homunculus.
That's right.
Where do you see technologies that have developed in the last 5 years or so changing the way you do this and think about the balance between trying to save somebody's life and the quality of life that they have left?
Yeah, no, that's a great question. I think there's a couple of areas where I see this innovation happening. And one is, I think we'll probably have a time where we have to keep fewer patients awake because we'll understand that, a direct cortical stimulation positive or these areas of brain that we say and we turn them off by delivering a small electrical charge, we'll be able to identify those probably non-invasively, or at least a close correlation of them. The others are to not just map for ourselves as providers, but for patients, what long-term cognitive behavioral outcomes look like. And so again, we don't actually have very good tools to prognosticate for patients. Patients right now, if you have a diagnosis today, meaning after this conference, I'll go to the hospital and I'll meet two people who are literally being diagnosed with a brain tumor today. They're going to make decisions for now, right? They don't really have a concept of what life is going to look like in 6 months, 12 months, 18 months down the road. And we don't, as providers and scientists, don't have a good way of prognosticating for them anything other than survival estimates. So what do cognitive behavioral outcomes look like for them so that they can maybe help make these decisions up front that are more in line with their goals of care, and also maybe start to modulate their lives to think about, the sort of services and the sort of activities and sort of things that they'll need to live the fullest life throughout the trajectory of their disease. These are just data points, right? And these are data points we just haven't integrated them together using current standards. And when we do that, I think it's going to be a game changer for the field and for patients.
So it sounds like one of the things that is going to really make a difference, because I'm listening to your talk, thinking of your lab work, and where we are with respect to all the single cell sequencing that is out there, really advanced AI being applied to imaging and functional imaging these days. How close do you think we are to being able to have these two patients that you will see today deliver biomarkers that will tell us a little more about the aggressiveness of that tumor, the invasiveness of that tumor, the energy of that tumor, which is something I personally had not thought about until listening to your talk today. How far away are we being able to harness these kind of things that truly have exploded in the last 5 years?
That's a great question. I think in terms of predicting survival outcomes, we're closer, meaning we can understand the genomic footprint of what type of tumor and what type of cells are going to be bad actors. Predicting the treatment response, meaning how an individual patient will respond to any individual type of treatment we give. We're further behind with that. I think that is, we could use big investments in capital and a willingness to get more patients in trials to help with that sort of data. I think we're quite a bit further off in terms of putting that together in terms of survival outcomes predictions, response to treatment predictions, and behavioral outcomes, kind of functional outcomes all into one. I think we would need many, many more patients and a lot of resources to do that. But if we can figure that out, and I'll put a plug in for just the number of patients that are involved in these sort of studies for us. It's well under 20% of patients in the United States that, as you know, that are treated with brain cancer that are involved in any sort of patient-facing research, whether it be therapeutic or just clinical outcomes, and even fewer that we even talk to and engage about this. So, many of us in the field, and as well as the public and social media, we all need to put our heads together to figure out how to engage the community better so that we can make better tools and have better prognostics and better things and options for patients if we can just get the word out in a little more comprehensive manner.
Great. So picking up on that, there are obviously here at this conference and many others, there's a big explosion in digital health, interest in digital health monitoring, employing social media, both for creating awareness and for being able to track activity. How comprehensively are those kind of approaches used for remote monitoring of patients that you've seen before?
Nascent right now. Very, very little.
Got it.
But I'll tell you, I'm encouraged because I'm starting to see the first few studies come online that are bottom up. And by that, and you probably know what I mean by that. When I say, when we have a new tool or technology or something, it's often lab or hospital systems down to the patient. And the truth of the matter is that increasingly we probably want a bottom-up approach where patients find out about this stuff, and then they engage and ask for more and more of it. Even the study, I can count on one hand, a couple of fingers, the number of people that engage with, again, clinical research or health systems or whatever, that are doing a bottom-up sort of research approach, starting with patients and then going to health systems and academic settings. But if we get more of that bottom-up type of approach, then I will tell you the world would get out much faster.
And so we need more people and more data.
Yeah.
I was involved quite a long time ago in the pulling together of a database by the Brain Tumor Foundation. They had this portable MRI that was staged in New York in different places.
I remember that.
And they just imaged the heck out of people looking for the beginnings.
That's right.
And they found lots of incidental findings too that weren't necessarily covered in consent.
That's right.
But it was the beginning of me looking and thinking, okay, not everybody can get an MRI.
That's right.
And everybody who suddenly has something not quite working right goes, oh my God, I have a brain tumor. Often you don't.
That's right.
Where do you see the role of I guess, putting together the fossil record of all the patients that have and how that appeared, being potentially used with machine learning to help us develop predictive patterns that could be used in an online digital health caring diagnosis.
Yeah, you're getting to such a huge point about access and screening. Before you make digital or AI-based platforms, you have to have a platform of enough people that are imaged kind of homogeneously across the U.S. In my lab, we ran a study recently from actually being led by one of the volunteers at this BrainMind Summit, and she's really focusing on the the distribution of neuro-oncology specialists across the United States.
Fabulous.
Before you even get to a scan.
Absolutely.
You know, the average distance across the US that someone has to travel to see a neuro-oncology specialist is 49.9 miles, with a huge variability from a few miles to well over 150 miles.
Right.
That's once you even have a diagnosis.
Right.
So to answer your question more directly, strategies like AI augmented low field strength MRIs. Right. They don't require shielding.
No.
Those could be, if there was enough will and thought, those could be strategically placed, specifically placing them in areas of the country that don't have.
Underrepresented.
Correct. Right. You can put those in a CVS or a local health center, and so those sort of opportunities are where I think AI will have the most immediate impact. Because again, these AI augmented low field strength MRIs, as just one example, are really shown to be really nice screening tools, actually.
Right. And the analytics have got so much better in the last couple of years for really pulling out the contrast.
Correct.
No, I hear you on this. I have a huge issue with the accessibility issue across the board with respect to not just this country, it's other countries
too.
for
sure, all around the world, for sure.
But generally the people who do get access to the neuro-oncologists are close to large centers that have a privileged component to them.
That's right.
So I'm completely with you on this one. Truly doing incredible work.
Thank you.
What is your dream over the next 5 years with all the people that you could assemble and the expertise and unlimited funding?
Yep.
What is your dream of where you can put yourself out of business?
Yeah, well, that's a wonderful question. And I think I'm going to say this in a way that I think we'll get here. We need to develop for patients drugs or whatever, non-invasive measures, implanted devices, whatever it might be, that can modulate neuronal activity that influences cancer biology. So neuromodulation of cancer, I think, could be a game changer for the field. Whatever mechanism works the best and is the most accessible and scalable for the population, because it's really undeniable the fact that the organ in which a cancer sits in influences the biology of the cancer. And that shouldn't be a provocative statement, right?
That was a really clear part of your talk,
right?
Which made a lot of people sit up.
And it should be pretty intuitive too, right? But the fact that that happens and that exists means that our thought process for cancer needs to be similar to our thought process for movement disorders and epilepsy.
Absolutely.
And rehab measures for rehab therapies for stroke. It fits into that same paradigm.
You bet. When I was listening to your talk, I used to work in brain injury and stroke modeling. And obviously, getting the right physio and occupational therapy on board is absolutely ASAP to enhance plasticity and begin self-healing is huge there.
That's right.
But you're talking about actually capitalizing on that experience to change the physiological input into areas that have a tumor to slow down the growth of a tumor, which
applied therapeutically. It absolutely should be.
Which I thought was fascinating. So
we're going to get there.
Really mind-blowing, I think, for many people who would not think that changing behavior could slow down actually the molecular pathways that are driving the growth of that tumor was amazing. So thank you for your work.
Thank you for having me. Events like BrainMind are so critical for bringing together investigators from both academia and research and industry together because, again, we don't have many settings in which we come together. And truly the answers are in these intersections, in these back of the room conversations after the talks where everyone gets inspired to not just think about the latest science and the advances from that science, but then how to apply it to patients, which is often outside of the realm of the academic setting. It's maybe best in other settings like industry. So you erase those silos in any setting or conference or summit where you break down silos and allow people to smoothly interface in between, our previously separated areas is always going to result in good outcomes.